All right, so everyone will get started now if we want. Marianne Given is a experienced lung transplant coordinator at the U of A. She has graciously agreed to walk us through the process as well as her day-to-day
Slide that over
role.
to the screen.
Pardon?
I'm not sure who was speaking. Someone was speaking.
Oh, okay. So I will get started. All right, Marianne, so why don't you take a moment just to introduce yourself and your background?
Okay, great. Thanks for asking me to speak to you guys. Appreciate that. I'm a nurse at the U of A hospital. I've been working in Edmonton actually as a nurse for 41 years. It's been a long time. I graduated from the Misericordia and then I moved over to the university in 1989. And I started working on pulmonary then. And so I've been involved in the lung transplant world from the very early days. We started doing lung transplant in 1986 at the U of A hospital. And so I've been privileged to be part of this whole thing since 1989. Yeah, so I'm a mom. I've got 4 adult children. I'm a grandma as well. And I'm looking forward to retirement actually later this year, hopefully in the fall. And yeah, looking forward to enjoying some time with my kids all over the world. They live all over the world. And then my husband and I want to explore the Gulf Islands on the west coast of Canada. So that's goals. But I wanted to talk to you a little bit about lung transplantation. I've been a coordinator for lung transplant since 2006. And before then, I was working on the pulmonary unit. And I also have some experience in the cystic fibrosis clinic and then working respiratory outreach. And I also worked on the multi-organ transplant unit when it was developed in about 2002. So it's been a very gratifying career for sure. So yeah, so lung transplantation is thought of as a final therapeutic option when all their medical management has been exhausted if a person has chronic lung disease. And so at the U of A, we offer lung transplant and combined heart-lung transplant. And you guys just ask me questions if you like as we go through this, or we could save questions till the end too. I'm pretty flexible. So if you want to flip to the next slide, thanks. So our transplant process then, the timing of listing someone for a transplant can be a tough decision for the physicians. They want to make sure that they don't list someone too early or offer transplant too early. And of course, we don't want to wait too late till the person is too deconditioned or frail for transplant. So that decision is contemplated for quite a while before the timing of transplant is offered to a person. So we receive referrals from the respirologists in the Edmonton area. And also, I should say, we have expanded. Our program in Edmonton has expanded to offer transplant to everyone living in Manitoba that needs lung transplant, everyone in Saskatchewan, all of Alberta, some of the Northwest Territories, and also the interior of British Columbia. So we receive referrals from respirologists in those areas and also family doctors. And so there are four transplant programs in Canada. There's one in Vancouver, and then there's ours, and then there's the big one in Toronto, and Montreal also has a program.
Marianne,
Yeah.
I just had a question from one of our Facebook attendees. What is the rationale between or behind putting someone on the transplant list too early? Like, why is that a bad thing? Would not earlier be better?
That's a very good question. So what our physicians always tell our patients is that we're try and get as much out of the person's native set of lungs as possible, because once we go down the route of transplant or the road of transplant, there's no turning back. So, then we're exposing a person to the big risks of rejection and infection and complications associated with transplant, and there's no turning back. So we don't want to list someone too early because because the success of transplant is kind of a limited thing. Our survival rate our median survival is 10 years now. So if let's say, we could have gotten 2 more years out of someone's life or lungs with a decent quality of life, if we transplanted them 2 years earlier, then, we might be robbing them of good quality of life at the other end of the equation. Does that make sense? Does that
Yeah,
answer the
it
question?
does. Yeah.
Yeah. Yeah. So it's a big decision. Yeah. And so then our physicians receive those referrals from the respirologists, and they make an appointment for you guys or for people waiting for transplant on a Thursday afternoon. And they spend about an hour or 2 hours with the family and the recipient, the prospective recipient, to go over all the risks and benefits of transplant. And they're also looking for any absolute contraindications for proceeding with transplant. And I'll talk a little bit about the absolute contraindications in the next few slides. So if there are no absolute contraindications to going ahead with transplant, then the physician will send that person's file on to myself or my colleague Gilda, and then we'll organize an evaluation for transplant. Okay, next slide is good. So there are a number of phases of transplant. So there's the assessment, which is also known as the workup. And then if you want to click the next button, sorry, Jamie.
No,
And then we'll talk a little bit about acceptance and then waiting for a lung transplant. And then I'll talk to you guys a little bit more about the surgery or the transplant itself. And then I'll talk a little bit about recovery and rehabilitation after the surgery. And then I'll talk to you a little bit about living with transplant for the long term. And then, yeah. So the assessment or the workup for lung transplant is quite a big assessment. It takes about 5 days, I would say, of dedicated appointments with some of our multidisciplinary team members, and having lots of diagnostic imaging done and some blood work and lung tests and those kinds of things. And then once all of that is done and all the results are back in, then we put together a comprehensive report, and then I give that to the physician that the person would have met on that Thursday. And then that physician would present all of those results to our multidisciplinary team. So our multidisciplinary team is made up of a lot of healthcare professionals, and that would be our respirologists and surgeons. And then we have our nurses and our dietitians and our social worker and our physiotherapists, occupational therapists. Who else? Who else do we have there? Social worker, did I say that? Yeah, so there's quite a few people present at that presentation, and everyone sort of weighs in from their own professional perspective regarding any risks that they may have picked up during the assessment.
Is this usually done during what they call the rehab time, when you go to Edmonton for the period of time to go through rehab?
So it's done before that. So yeah, the
Before that.
rehab part would happen after the person has been accepted as a good candidate for transplant. And yeah,
Okay.
we'll be talking about that. Yeah, you've heard about that boot camp.
Well, I've done all of the tests, like the yearly tests on my entire body, and I'm currently a status 0. So I'm
Oh,
just
okay.
wondering if what time that is around the rehab program.
Right. Yeah, so yeah, we usually get people involved in the rehab program when we know that there's more of an
Right,
imminent chance of getting activated on the list. So sometimes
right.
people wait in the status 0 kind of stage for a while before they move ahead with the rehab program, and then the activation on the list.
So the workup, I'm in Calgary, so the workup as an outpatient is done in Edmonton?
Are you followed by the Calgary team? There is a Southern Alberta transplant team. Are you
Yeah,
followed?
I am followed by them too.
Oh, okay. Yeah. So then when they feel that you're ready to be almost imminently kind of activated on the list, they'll ask us for a spot in that rehab program, and then we'll bring you up for that.
Right. Okay.
Mm-hmm. Good question. Okay, we can do the next slide. So yeah, absolute contraindications to lung transplant can be if someone is continuing to use nicotine substances, or if they're smoking, we definitely want someone to be abstinent from smoking for 6 months before we move them ahead for transplant. Or if they're using any other substances to excess. So, alcohol or illicit substances are some of the things that we want to manage before putting someone forward for transplant. HIV is an absolute contraindication to transplant as well. If we found cancer in any of the tests, then we would have to stop the process and manage the cancer. And then the other thing is cirrhosis of the liver. If it's advanced, then that could be an absolute contraindication to transplant as well. Any questions about those?
Oh,
I have another one.
Sure.
Sorry. So you're saying 6 months for smoking, so it's not like a automatic you're not going to happen unless you quit? There's still people that are smoking that can be put on the list?
Oh, very, very rarely.
Okay.
Yeah, very, very rarely. Yeah, we definitely would prefer everybody to be a non-smoker for at least
Right.
6 months before we go ahead and activate them. Mhm.
Okay. Okay.
But sometimes we have very, very urgent referrals. They might be referred to us,
Right.
might already be in the intensive care unit on life supports, and they may not have had the chance to stop smoking for 6 months before they got into this terrible
Okay.
health crisis. So in those cases, we make exceptions. But
Okay. That makes sense.
mhm,
Okay.
yeah,
Thank you.
yeah, great. Okay, next slide, I think.
So, Marion, we do have another question from the Facebook attendees. What
Okay.
about vaping? That doesn't contain nicotine.
Right, good question. So vaping is one of the things that we want people to not be doing as well. Because our physicians have been going to some conferences where they do talk about the health risks of vaping, and
Mhm.
they found that there's quite a few um, substances that could be inhaled into the lungs, including like some oil kinds of droplets and some even the plastic from the thing that holds or heats up the substance.
Yeah.
So,
Yeah.
so they prefer people not to be vaping as well.
Yeah. So I can actually elaborate a little bit on that.
Good. That's
We've
right.
we've done some support of research at the U of A and other organizations regarding this. And even if the vaping liquid doesn't contain nicotine, there's a lot of flavorings like the menthol or especially the strawberry flavoring, and a lot of the preservatives that they use when they're heated, they can create toxic substances that damage your lungs.
Yeah.
Yeah.
Yeah. Thank you for that. That's great. Thanks, Jamie.
Now, that was a good question for them to ask, actually, because yeah, I'm like, would it really count if it
Mhm.
doesn't contain nicotine? I think a lot of people would think that'd be an exception.
That's a very good question. And the people that produce these vaping products are trying to sell it as a way to get off smoking or to
Hmm.
break the cycle of smoking. But it's found that there's just as many, or there's quite a few um, risks associated with vaping that are just becoming apparent now.
Yeah, exactly. And I think yes, it's used as a smoking cessation tool, but if it just makes you choose vaping instead of smoking, it's not really a cessation tool.
Mm-hmm. Yeah.
And they can do blood tests to check for tobacco in our system, can they not?
We usually do urine tests. It's called
Yeah.
a nicotine metabolite that we check for in the urine.
So that wouldn't show up on it if
I
they're
guess not for
vaping.
vaping. Yeah.
Yeah,
Yeah.
that's a good point, actually. I don't think there is a test yet for vaping, simply because other than nicotine, there's a huge variety of different chemicals that they can use. I think there's over 250 different possible combinations.
Wow. Yeah, yeah, it's too bad because yeah, it's just ending up in lung damage for sure.
Yeah. So the Alberta government did recently announce a tobacco and vaping reduction strategy. So we're hoping what they'll do is bring about legislation to regulate what manufacturers can put into these vaping combinations, just so we can do that study and be able to tell people, this chemical can do this type of damage or whatever. And then
Mhm.
eventually that can lead to having a, diagnosis test for it where we can
Yeah,
actually tell the person is vaping because we've done this test.
right. Yeah. Well, that's good. There's good work being done. Nice to know.
Yeah, yeah, I'm really glad they've announced a strategy. We're just gonna, push and hopefully hope for things like flavor bans
Hmm.
or just making it a lot harder for underage Albertans to get
Right.
access.
Yeah, some of these underage people are who are being targeted on this marketing as well to
Mm-hmm.
get them hooked at a young
Okay.
age.
Oh, so it looks like we have a follow-up question to that.
Okay.
Um, Oral nicotine pouches. So I think maybe some of you have seen ads for Zonic or other things. It's this little pouch that you put into your mouth, and it's a way to get nicotine into your system that isn't vaping or like a cigarette. It's almost like a new
Snuff.
generation tobacco club that you would chew on, except it's flavored.
Oh, okay.
They are wondering if that would count.
Yes, that would count. I guess the basis is that they just want people to not be dependent on nicotine substances at all, because we want our recipients to, once they've got a transplant, to take care of the new lungs that they receive, because they're such scarce organs and scarce
Hmm.
resources, that we want the best outcomes as possible. So if someone hasn't really dealt with that habit of habit forming of nicotine, whichever use there, whether it's ingested or inhaled or vaped or something, then they're at risk of damaging the new lungs, and we just don't want to have that as an outcome for our recipients and for our donor families. Um, yeah, so I think that's the bottom line, I think.
Marianne, are there ever any partial lung transplants? Like maybe like a part of a lobe or
Yeah, yeah. Well, there aren't anymore, but we have done at the U of A, we've done 7 living lobar transplants. That's what that was referred to as.
oh,
Um,
okay.
but that fell out of favor a number of years ago, because what was happening was that we'd have to have 2 separate donors for one recipient, and each donor would donate a third of their lung capacity, so one lobe,
Hmm.
so 30% of their lungs. So then that would endanger 3 people's lives, really. Like the 2 recipients would have pretty major surgery to have this lobe of their lung removed, and then the risk of the surgery on the recipient. So worldwide, living lobar transplant has fallen out of favor. And then there
Okay.
are questions about whether or not they can cut down lungs. So if we
Hmm.
have donor lungs that are too big for our recipients, can they cut them down? But that isn't well regarded either, because of the surgical trauma to the lungs, and then the resultant complications post-transplant, post-operative complications.
Okay,
So
so one of our Facebook attendees is asking, how long is a donated pair of lungs good for before it gets transplanted?
that's a good question. That's one of our limiting factors in Canada, because we have such a big geographical region. So donor lungs are only really viable for about 6 to 8 hours outside of a human body or without any circulation. But we have been working on that as well over time. For a while, we had the ex vivo lung perfusion, lung in a box kind of
Oh, is that
system.
Darren Freed and Dr. Nagendran's
Gendron, yeah,
invention? Yeah.
they developed that. And we were using that for a while, but it is very expensive. So AHS has kind of put a hold on that for now, because each time we use it, I can't even remember, it's just very, very expensive. But currently we have another option available to us, and it's a cooler that we can cool the donor lungs down to like 10 degrees Celsius, and then that will preserve them, you know, almost put them into like a little bit of a suspended animation for a number of hours, and that can extend the time of that the donor lungs can be outside a human body without the circulation. Yeah, that's so we are limited. We can't get organs from further away than Quebec, really, because the Maritimes are too far away. But we do get offers from other parts of Canada for sure, and some of the northern United States. Good
Okay,
question.
interesting. Yeah, that's a good question. Sorry to derail.
Oh, no, that's very interesting. I'd prefer to have a conversation than have just this didactic kind of PowerPoint that's kind of boring for you guys. Okay, next slide, I guess. So I talked about absolute contraindications, but we also have a bunch of relative contraindications or risk factors for transplantation. So the optimal kind of body mass index for recipients is between 30 and 16. So we don't want anybody over, really, actually, I should say 30, 32, I think we've stretched the envelope a little bit on the body mass index. So if someone has a body mass index over 32, then it really does put them at a big risk for post-operative complications. And then conversely, if their body mass index is less than 16, then they're nutritionally challenged, and that also puts them at risk for recovery from a surgery as big as lung transplant. We have stretched the age envelope. I put there 75 as our maximum for age cutoff for transplant, but we have done a separate study on our recipients that are 65 years old and older to look at their mean survival time. And if we're transplanting someone that's over 65, we find that their median survival time drops down to about 4 to 5 years. Whereas if you were younger than 65, your median survival time is 9 to 10 years. So that does have an impact. So we're very careful about transplanting anyone over the age of 70. We want to make sure that they're as intact as possible and that they don't have any other disease processes going on, like high blood pressure or diabetes or heart disease or those kinds of things. If someone's on mechanical ventilation in an intensive care unit on ventilation, that does put them at risk for transplant. So we watch them carefully, and it's almost a day-to-day decision to determine whether or not they're still a strong enough candidate to go ahead with transplant. If someone has renal disease, that's also something that we look at as well, because we know after lung transplant, the kidneys are going to struggle with the immunosuppressive medications that they're going to need post-transplant. These aren't absolute contraindications, but they do raise the risk of transplant for sure. Psychosocial instability, if someone doesn't have good supports in their life, or if they struggle with significant mental health issues like really severe anxiety or depression, that does pose a risk as well, because again, some of these medications can impact a person's mood and mental health. Poor circulation. So if someone has peripheral vascular disease, that can also be a relative contraindication. Osteoporosis means brittle bones or bones that have lost some of their calcium and integrity. If someone is also on prednisone over 20 milligrams a day, that puts them at risk for not being able to, for the tissues not to be able to heal very well post-operatively. If a person has a chest wall deformity, like a pectus excavatum, where their rib cage kind of caves in, or if they have a scoliosis, that could be a risk for transplant. Infections, we can have people that might have come across, like especially with lung disease, you can get some pretty tough bacteria or fungal infections that are hard to eradicate, and sometimes even after transplant, those infections can come back, because those bacteria and fungus can also reside in our our airways, our nasal sinuses or our upper airways. And then when we immunosuppress a person, then it's harder to manage those really, really resistant fungal infections or bacterial infections. Hepatitis can be a risk as well because actually, I should say that, you know what, we've made a lot of ground on hepatitis. There's been some really good development of hepatitis C viral medications, and also hepatitis B is managed much better than it was in the early days. Non-compliance or non-adherence to medical regimens can be a risk after transplant. You know, if someone's not very comfortable working very closely with the medical team, then we know that that's kind of a risk, because post-transplant, it is a significant regimen that a person's going to have to follow to have the best outcomes possible. Previous chest surgery can put someone at risk as well, because when a person's had chest surgery, then the chest wall can really adhere to the rib cage and can be very difficult to get lungs out. So that poses a risk as well. And if a person has cardiac disease like left heart function, or even now we have right heart function that can be associated with some pulmonary diseases that can put someone more at risk as well. Any questions about those relative contraindications? There's quite a list there.
So I have a question about vaccinations and immunizations. What vaccinations and immunizations should a person make sure they have to reduce the risk of contraindications?
Oh, that's a very good question. There's quite a few. So we have the public health clinics have our list of our recommendations for people going through solid organ transplant. So COVID is definitely one of them, that we really want people to get their COVID immunizations pre-transplant, because we've learned through COVID, the COVID pandemic, that people that have some immunity going into transplant will manage much better post-transplant if they do get a COVID infection. So COVID for sure, hepatitis B for sure. Shingles is a really, really important one to have, and the pneumococcal ones, meningococcal. Of course, you have to be up to date with your diphtheria, tetanus, and pertussis. What else do we have out there? Shingles. The flu shot is always really important to have some protection on board there. And I think there's other ones like the tetanus ones. They want people to have boosters. They want people to have their primary series of mumps, measles, and rubella, German measles. So there's quite a number, but yeah.
Can I ask a question about the prednisone?
Sure, yes.
Is it over 20 milligrams a day for a specific period of time? Or what if someone has been on a lower dose, but for a very long amount of time?
Yeah, so that's a good question, because sometimes we use prednisone with lung diseases to
Okay.
handle exacerbations and to and try and get infections and inflammation under control. So if someone's on a steroid pulse for like 50 milligrams for 5 days and then they're stopped, then that's okay, because the tissues, your tissues will rebound afterwards. But if someone is on a smaller dose, like 5 milligrams up to 15 milligrams, maybe even 20 milligrams, then we find that their tissues will recover post-transplant. But over 20 milligrams, I've heard the surgeons describe the tissue as they're trying to sew the airways, join the donor airways to the recipient airways, and to try and close the muscular kind of tissues after transplant, as trying to sew through wet tissue paper. It just makes the tissues just so friable.
Okay. So
Yeah,
it's more the higher dose than it is the
right,
length of time.
right. Yeah,
Okay.
yeah, I would say so. Good question. All right. Next slide, I guess. So then once we've determined that a person's a good candidate to go ahead through transplant and be activated on the list, then we activate them, we assign a status, either status 1 or status 2. And we do have status 0, as you were saying, Megan. Status 0 means that a person has been through the assessment for transplant and they've been accepted as a good candidate, but we haven't activated them on the list. And when we go to activate them on the list, then we assign a status either 1 or 2. And status 1 tells the physicians that the person has a lung disease that's not deteriorating super quickly and that they have a little bit longer to wait for a good offer of transplant than someone who has a more aggressive lung disease that's deteriorating and losing ground very quickly. Yeah, that's status 1 and status 2. We also have a little bit more of we have another tool that we use, which is called the cumulative allocation score, which that we use on our list so that the physicians can look at the various recipients and see who's got the higher score, which means that they're definitely losing ground more quickly, and so then they can make a decision on who would be the best recipient for a specific offer of transplant. Any questions about that one? Okay, we'll go on to the next slide. So once you're active on the list and waiting for an offer of transplant, we really encourage people to stay as physically active as possible. And Megan was asking earlier about the pulmonary rehab program or the boot camp that we try and get everyone through here at the U of A hospital for transplant. And so this boot camp that she was referring to is a month-long program where we have people coming to the gym every day and exercising and learning how to exercise with their lung disease, learning how to exercise safely so that they can maintain their muscle mass and their stamina and their cardiovascular health. And then there's some education sessions as well that talk about signs and symptoms of infection and rejection and proper nutrition and relaxation strategies and all those kinds of things as well. But at the end of that 1 month of the boot camp, what the physiotherapists do is they give the recipient a homework to be able to continue on exercising while they're waiting for a transplant so that they can be as strong as possible going into this major surgery. So the wait time for lung transplant is quite variable. It could be as quick as 1 or 2 days, or it could be 2 years or longer. So our average though for time on the wait list is 6 to 9 months here at the U of A hospital. And while you're waiting for a transplant, there's frequent clinic visits, usually about every 3 months. But if we're really worried about you, we want to check in with you almost every month just to make sure that you're still managing well with, as a candidate for transplant and you're still healthy enough to go ahead with transplant. So it's a busy time and it's an uncertain time for sure. There's the whole unknown of when you're going to get an offer of transplant or even if you're going to get a transplant in time to save your life. We've worked really hard over the last number of years to decrease the deaths on the wait list. In the early days, we would lose 30% of the people waiting for transplant. So that was a tough statistic for us. We have got that down below 25% now, so we're happy with the improvements that we've made there. Yeah. Any questions about that?
Of course. Me again. Sorry, I want to know as much as I can about everything.
No, that's fine. That's great.
Do you still ask that a support person is with us when we go for the rehab?
That's ideal for sure, because then we can also teach that support person what their role is in all of this, and then they can become familiar with the site and with all the people on the team, and it just really brings down the anxiety. So in a perfect world, that support person would be there with you every step of the way. But we have a number of people that enlist a team of people to support them through
Right.
that program as well. And so then, sometimes people take a week at a time or a few days at a time, and that works out well as well.
Okay. When it was mentioned in passing by my doctors that it would be preferable that it was the same person, so the doctors aren't always having to relay information over and over to different people
Mm,
every time,
yeah,
just to kind of cut down like the middlemen and have one person who knows everything
yeah,
instead of a whole bunch of people that know a little.
yeah. That's true. That's very true. Yeah, nice to have nice to have a consistent support person. We actually did a study as well and noticed that people that have reliable supports have better outcomes post-transplant as people that, we have transplanted people that have very weak supports or maybe not even any supports, and they really struggle post-operatively, and their outcomes are affected by that as well.
Thanks.
Okay,
I have a question, if that's okay.
sure, yeah.
I was just wondering if you could give an idea of how many people in Alberta are waiting at any one time for lungs, and how frequently the surgery is done. I know that's a bit donor dependent, but I'm just curious.
Well, that's a good question. Our I was saying to our team has been talking about that lately. It's very topical, really. Our list is very small. I've never seen our list this small, and I think right now we only have about 30 people on the list. For all of that big geographical region of Manitoba, Saskatchewan, Alberta, Northwest Territories, and part of British Columbia. So, and I think part of that is because we've done so many transplants last year and this year. Last year we ended up completing 73 lung transplants, and this year we've already done 28 lung transplants. So we're almost transplanting people faster than we are getting them on the list, which is a good thing in a way, but it also we want to make sure that we're not missing any people that could benefit from transplant. So we're reaching out to our colleagues in the wider region to make sure that they're making that they know that transplant is still a good option for people with lung disease, and that they're sending these referrals on to us as well. So I have seen the list over my time as a coordinator as big as 65, 68 people. So 30 people on the list is pretty small, but yeah. So our largest number of transplants ever, I think, was 76 lung transplants in a year. So we're on course this year to top that number for sure, because we're only 14 or 15 weeks into the year and we've already done 28 lung transplants. So we've been very busy for sure. So
Why do you,
that's about 2
sorry,
transplants a week, I would say.
what
Yeah,
do
that's
you think, what do you think contributes to it being so there being so low an amount of people on the list right now?
So what I was saying is I think it's the number of transplants that we've done, and then also the number of referrals. And I think COVID played a part in that, is that, some people weren't going to their respirologists or their family doctors during those COVID years. And so we probably lost some people that could have benefited from transplant during those 2 or 3 years of the pandemic. And then also some people, just haven't been followed by their respirologists, and maybe now are getting back to being followed regularly, and getting on the radar of on our radar, knowing that transplant would be a good option for them. So we're waiting for those referrals to start coming into us, and we're kind of worried that we're going to get a big backlog of referrals. So I think, does that answer it? It's the number of referrals have been lower because of the pandemic, and then the number of transplants has been higher, I would say.
Mm-hmm.
Yeah.
Yeah, it makes sense. I just wondered like why is it, why is some years it's so high and some years it's so low? Like,
I do know too that some of the family doctors and respirologists out in the maybe the rural areas might not. We're trying to do sort of an outreach to these other physicians to let them know that that we have stretched the envelope in terms of age of the recipients or candidates for transplant. So I think that there might be some respirologists or family doctors in the greater Alberta that don't realize that anyone over the age of 65 could still be a candidate for transplant. And so they might not be making those referrals to our program. So we're trying to educate family doctors and respirologists as well.
Do you think? Sorry,
Quick
go
one.
ahead.
Is it also true that the supply side is also better, that there is more awareness, especially after the Bronco accident? People are more willing, or many more people have volunteered, and donation, and the organ donation is happening more.
Oh, yes, for sure. There's a couple of things there for sure. I think there's much more public awareness of donation and much more. I think I just saw this week that we used to have, I think, 7 donors per million population in Alberta. That was quite a few years ago. And I think now we're seeing more like 20 donors per million population becoming the norm. So much more public awareness. And we've done a lot of work on, just getting the registry out there, getting awareness out there, and just, educating the public. And then we have the horrible opioid crisis that is resulting in donors becoming available as well, which is such a tragedy. But that is part of the the equation as well.
Right. Yeah. Thank you.
Marianne, I just have a question from our Facebook attendee. What would disqualify someone from being a lung transplant donor?
Very good question. There's quite a bit of criteria. And the HOPE program is the program that works with on the donor side of this whole program. As it stands for Human Organ Procurement and Exchange. And Health Canada has a very long and strict list of requirements for donors. So things that would make a donor not a good candidate for donation would be if they had cancer, if they had cancer anywhere in the body that, although I shouldn't say not cancer anywhere, but sort of a metastatic cancer, because you can have there's a certain type of brain tumor that doesn't metastasize that could be acceptable for transplant, the donor organs could be. But cancer, I would say, previous lung disease, like if they had asthma or COPD themselves or some other lung disease, if they used substances to excess that could really damage the lungs, that would also make them not a good candidate or preclude them from being a candidate for donation. Infections can be that as well. So there can be some infections that we just couldn't manage post-transplant, and we just don't want to pass that on to the recipient. So certain types of bacterial infections, viral infections, fungal infections, trauma to the chest. If the lungs have been really damaged in whatever crisis the donor went through, then we can't use those organs. So there's a number of things for sure. I hope that answers that. I would say, I just want to let you know that out of if we have 100% donors, we probably only accept 40% of those donors because of the other risks that preclude them from donation.
Okay. Oh, wow. I didn't realize it was such a low number. But I guess that does make sense, hey?
Yeah. If they had a really extensive smoking history as well, then that could also, damage their lungs. So sometimes if they've come from countries that have tuberculosis, then we are very careful about accepting those. If a donor had HIV, we don't want to pass that on to the recipient. So there's quite a laundry list. Good question.
Yeah, like I don't know how far along they are, but I have heard talk about some preliminary research. I think it's still preclinical right now, where they're looking at ways to reverse the damage of certain organs for lung transplant and kidney transplant. I believe that they're working on it, but what they're trying to do is they're trying to use things like CAR T cell therapy. So that's an immune cell where they're going to modify it to attack things like cancer and etc. and other reparative cells to go to a potentially damaged organ that otherwise would be used for transplant and fix that damage so it can be used for transplant. I think that's really exciting. I
Yeah,
don't know how far away we are from that becoming a reality though, but
Yeah.
it is like it's heartening to hear because it is difficult to find transplantable organs regardless of where in the body it is sometimes.
Mhm. Yeah, yeah. There's so much research going on in the background. It is really encouraging, and I'm so grateful that there's so many research sort of physicians and nerds out there
Yeah.
that are very
So
interested in that
so
because
Dr.
they
Weatherald at the U of A, we have a research grant program that we go through the province and we fund research depending on what sort of research lung health researchers are doing. So he's actually doing a study starting this year that is going to be looking at the different variables involved in the lung transplant process, as well as pre and post care. And he's going to be, I think he's going to be looking at outreach to patient and patient families as well as healthcare staff within the
Mhm,
next year or so. And so
mhm.
what he's looking at is ways to improve this system. So once I have more information on that, I'll let everyone know.
Yeah, he's actually already started that. He did
Oh, has he?
his
Okay,
research
excellent.
coordinator has been contacting, she's been in our clinic and has been
Hmm.
consenting recipients to the study and getting their input into what questions they want answered.
Perfect.
Most
Yeah,
important
that's he's ahead of
transplant.
schedule. That's perfect.
Yeah.
That's rare in research.
Yeah.
But yeah, it's exciting. I'm glad to hear that that's already, underway.
I think we go to the next slide now.
Okay.
On. All right. So yeah, as I was saying, waiting for the offer of lung transplant probably is the hardest part of this whole journey because of the whole unknown of when you're going to get an offer or if you're going to get an offer. And so we've taken a few quotes from some of our patients about their challenges while they were waiting for transplant. And you can see them here. One person was saying waiting is so hard. They do get worried and they do get scared for sure, because you are looking at end of life issues and you're trying to stay hopeful and strong, but you're also trying, planning for the worst and hoping for the best. So it's an uncomfortable space to be in for a while. Someone said that they almost died twice already, but they want to live. And someone says, they want to be hopeful. And the last quote says, good news for me means bad news for someone else. That if they got new lungs, that means that someone else died, and that the family of that donor had to suffer a loss. And so that is something that goes through our recipients' minds while they're waiting for transplant. But what we've learned over time is that that people are dying from their own tragedies, and we're just very, very grateful that their family has the courage to offer out this gift of life. So that's waiting is the hardest part for sure. Okay, we go on to the next slide. So allocation of lung donors in Canada. I sort of covered a lot of this. So I should say though that with these 4 programs in Canada, we each have our own sort of geographical region. So if we have a donor in that region, then we look at the recipients in that region and try to offer out the donor from that area to those recipients. And if there isn't a match in that geographical region, then that program will offer the lungs out to the organs, the groups, the transplant programs closer to them. So We get offers from Toronto, and we also get them from Vancouver, and we also get them from Montreal. The donor, so when the physicians are receiving offers of donor organs, they look at the blood group of the recipients because the blood group has to be compatible with the recipient. And then also another requirement is the size of the donor lungs. They have to be compatible with the recipient because they can't be too big of organs to fit into the chest cavity, and they can't be too small because it really is such a mechanical kind of organ with the diaphragm and all of that. So we run into troubles if the sizing isn't compatible. And then the physicians also look at the status of our recipients, and they try and get to as many of the people that are status 2, you know, first, because those people have less time to wait for an offer of transplant. And then if there's nobody in the status 2 list that would match that donor offer, then they offer them out to someone that's in the status 1 category. Okay, next slide, I guess.
Looks like we have a question here. What is
Sure.
the geographic region for the U of A's program? Is it
So-
just in Alberta, or is it expanded from that?
Yeah, it's actually all of the region that we transplant for. So it's all of Manitoba. Really, donors from Manitoba should come to our program first, because we transplant the population in Manitoba, and then also Saskatchewan, and also Alberta, and the Northwest Territories. British Columbia, their donors would go to Vancouver first, but if they don't have a recipient, then Vancouver will offer those lungs out to us. So I hope that answers that. It was Manitoba, Alberta, Saskatchewan, and Northwest Territories would come through our program.
Okay, I guess they have a follow-up question. Given how big Canada is and the restriction for Quebec, why are there only 5 centers in Alberta, in Canada?
There's only 4 programs in Canada. And I guess it's because, you know, we've learned that there's kind of a minimum number of transplants that you need to do a year to be proficient at it and to have good outcomes. So we've learned over time that if Manitoba would be a perfect example of that. They used to have their own lung transplant program, but they were finding that they were doing less and less transplants. And the surgeon that was doing the transplants just felt that you know, he wasn't doing them often enough to be really proficient at it. So he retired from doing transplant and then just went on to do other chest surgeries. And then they closed down their surgical part of their transplant, and that's how we took on Manitoba. So I guess there's a kind of a minimum number of transplants that you need to do per year. And so, you know, the population across the country is quite varied. So Saskatchewan, if they wanted to have a transplant program of their own, they probably wouldn't be able to do enough transplants to be proficient and have good outcomes. So I think that's a large part of that. Yeah. I know the physicians probably be able to give you a better answer, but
I have a question.
Mm-hmm.
Do you call people on their own phone now, or is that like before where you gave them a phone or a pager? I'm aging myself to get a hold of them.
We retired the whole pager idea a while ago. You are dating yourself.
I'm aging myself.
That's funny. No, so we do, we call them on their cell phone or their landline, but we ask them to give us their primary contact. And then we also take their contact phone numbers of their support people, because sometimes we can't get a hold of the recipient.
Right.
So then we try their support people next.
How much time do you dedicate to getting a hold of them before you move on?
Yeah, that's a good question. We start to worry if we haven't heard back from them within 15 minutes to half an hour. We start to worry. So we really work hard at trying to get a hold of somebody within, half an hour of us learning of the offer. Because
Are you reaching out to our primary transplant doctor as well?
sometimes we do, yeah, sometimes we do. Yeah, we even have, on our consents, we have a health information consent that we give to everybody. It's an Alberta consent, provincial consent that the government has asked us to get from people that are waiting for transplant. And one of the questions on that HIA consent is whether or not we could contact the police in case we can't get a hold of them in
Oh, yeah.
time of an offer of transplant. And I can tell you, I've had to do that once or twice when we haven't been able to reach the recipient. It doesn't happen very often, but with the spotty cell phone service, or if someone is out at a lake and they don't have great contact, phone contact, then we have had to ask the police to go and track them down. And so some people, like, let's say they're camping in a remote spot, they'll tell the RCMP that, hey, I'm listed for lung transplant, and in case they can't get a hold of me, you might get a phone call that I've got an offer. So it doesn't happen very often because
It's not a call you want to miss, right?
no, definitely, because we will have to go on to the next recipient because they are such vital organs and such
Right.
commodity. We don't want to lose those organs for sure.
So what happens if you do miss the call? Are you moved to the back of the list again, or how does that work?
There's
Does
no
it
real
affect your place on the list?
no, I don't think so. I mean, we haven't had that situation very often. I can't even really think of when we haven't been able to get a hold of the recipient, but we have had people that decline the offer at the time of the offer of transplant, and then that does give us pause to think. And so we do put them on hold for a time so that we can bring
Okay.
them back into clinic and chat with them and see what their hesitation was. We try and do a lot of education up front so that people won't hesitate at the time of transplant offer.
But missing the call is not the same as declining it, obviously.
Right.
Okay.
Yeah.
Okay, Marianne, I have a Facebook question here. I realize it's after 8 o'clock, so I'll make it quick. What reasons do people give for declining a transplant after they've been on the wait list?
Well, I've seen people say that they're one fellow was just, when he did receive the call, I guess he hadn't really thought through the whole commitment to transplant and the whole the whole thing, and he was just so anxious. He couldn't imagine himself going forward with transplant, so that was unfortunate. We did have to put him on hold for a while, and then he took some time to think about that. Other people, it doesn't happen a lot in lung transplant, but I can tell you in liver transplant, sometimes people, I've had people say, well, I run a farm and it's calving time and it's just not good time for me to come in for transplant. Things like that, which, so quite a range of reasons. But in lung transplant, I would say we haven't had too many people hesitate. Mostly it's they haven't really had the time to really process the idea of what this commitment and what this option means to them, I guess. I appreciate you all coming. Thank you for your interest in all of this.
Thank you.
Thank you for
Very
answering the
good.
question.
Will this information also be shared like during at any other point, I guess?
Sorry, just so I understand your question correctly, do you mean like is it shared during the boot camp science rehabilitation program, or will this be shared with the support groups after the session?
Either one, I guess.
Okay, so the answer to both would be yes. So a lot of this information they go through with you during the boot camp, and we will have the video available on our YouTube in a few weeks, as well as we will pull some information from it just to give you guys more information, and it is on our newsletter as well.
Okay, perfect. Thank you.
Perfect.
You're welcome. All right, thanks everyone for staying late. Have a great night, and I will see you in May.
Okay,
you.
thanks
you.
everyone. Yeah,
All right,
nice
thank
to
you,
see all.
Marianne. That was a great presentation. Thank you for answering everyone's questions.
Oh yeah, my pleasure. I could talk about it for hours.
All right, great. All right, have a good night, everybody.